So I get the great pleasure of introducing Carmine Pariante, who is a professor of biological psychiatry at the Institute of Psychiatry, Psychology, and Neuroscience, also King's College London. And he investigates the role of stress and inflammation in the pathogenesis of mental disorders and in the response to psychotropic drugs, both in clinical samples and experimental settings. He's won a number of awards, and he'll give you a little bit of a taste of why this morning. But this includes the PNIRS Normal Cousins Award for Research in Psychoneuroimmunology, the 2017 Andrea Leadsom Award for Outstanding Contribution to the Field of Infant Mental Health, the 2017 NARSAD Distinguished Investigator Award, and the 2018 Art of Neuroscience Award. And I particularly like the fact that with his title today, he's intentionally being provocative. And as I'm having an allergy attack this week, the inflammation story is a little bit more relevant for me right now. So please welcome Dr. Pariante to the stage. Thank you.
Well, good morning, everybody. I want to thank Scott and Mary for not only for the introduction, but for having invited me here today. It's such an honor and a pleasure. I've been sitting in the audience like this for many, many years before thinking, wow, I wish one day I would be giving one of these lectures, and here I am. So to all the young people, you can make it, so don't worry about it. Now, you can see here that I'm quite active on social media. Let me just, so this is my Twitter ID. This is our Facebook page for the lab. Please do tweet. Remember the hashtag SOBP 2019. Say nice things about this talk if you want, preferably. Go on to the Facebook page so you see what we're doing. A couple of things I want to add to what Scott has said about myself. It's mostly about my editorial activity. So I'm the editor-in-chief of Brain Behavior and Immunity. It's a journal that publishes papers on psychoneuroimmunology and immunopsychiatry. I know that a lot of researchers in the audience would be interested in this field. If there is any papers, any authors that, of course, are not suitable for biological psychiatry, or that, dare I say, get rejected by biological psychiatry, please come and talk to me. I'll be delighted to be the second choice after biological psychiatry any day. And recently I also started another initiative. We actually started a blog publication called Inspire the Mind. It's on the Medium platform. For those of you probably know it, is a kind of American Medium, American blog platform that has publications so you can kind of concentrate on topics. And I write on it, my researchers write on it. We have guest writers from a variety of backgrounds, including patients or writers, social scientists, and so on. Again, please do Google it, visit us, and if you're interested in writing a blog on something exciting, please do contact me. So far, so good. This is kind of the positive emotion part of the lecture, if you like, things that goes well. The negative emotion really is kind of about science and research. So I think that I will talk about my own negative emotion during this 25 minutes or so, which has prompted me to use this title of mixing apples and oranges. Because, one thing you notice when you are in the field for some time and you do research for a number of years, things are never so easy as you thought they were. And so this picture, I'm going to use the metaphor of oranges and apple for a couple of things today. So I'll start with this. So you can see in this picture what research looked to me when I started. These were all kind of nice individual studies. One study showing, for example, that depressed patient had a high cortisol level. Another study showing that depressed patient have inflammation. Another study showing that depressed patient have childhood maltreatment. Another study showing that depressed patient had a history of maternal mental health problems. Kind of, identifiable specific risk factors all associated somehow in a univariate way to an outcome. But now, years have come by and I see my research more like this. a combination of intersecting, mediating, moderating orange and apples, all confusing. So I want to kind of give you an overview of the work they've done over the years to try to disentangle the interaction between inflammation and hypothalamic pituitary adrenal axis activity in depression, and how basically over the years I'm understanding less and no more than I used to understand 20 years ago. Now, it's not that I haven't tried to put things together. This is an editorial that I published a couple of years ago on kind of my 20 years of research. And it's interesting how the models that we're using are almost exactly the same. They're just becoming more confusing and obviously more complex than we originally thought. So we've used this model for a long time to try to understand how is it possible that patients with depression, not all of them, but most patients with depression have both hyperactivity of the hypothalamic pituitary adrenal axis, so they basically this hypersecrete cortisol, and have high level of inflammation. These are very simple models. The idea that stress affects the brain, which activates the hypothalamic pituitary adrenal axis, which in theory should keep the immune system under control because, of course, cortisol is immunosuppressant. And at the same time, also, the brain activates the sympathetic nervous system, catecholinergic innervation, mostly drives the acute inflammation, possibly the chronic inflammation, and the immune system responds to the stimuli by producing cytokines, which of course affects the brain, induce some of the depressive symptoms, possibly makes the brain resistant to antidepressant treatment. And to try to understand why, really, these two biological abnormalities coexist, we've kind of developed this model of glucocorticoid resistance. So the idea that even if cortisol level is elevated in this patient, cortisol is unable to exert the anti-inflammatory action simply because the receptor for cortisol, so the glucocorticoid receptor, is unable to transfer the signal in an efficient way. And so you have this paradox of high level of cortisol and high level of inflammation, even if the two things should actually cancel each other out. Now, of course, I wish that was so simple, and it was very simple at the beginning. This is one of the first studies that we published in this field more than 10 years ago now, where we measured inflammation and cortisol in a single blood samples, a fasting blood samples for very severe depressed patients that were actually inpatient, so admitted into a hospital. And we found, as we expected, high level of inflammation. This is IL-6, quite kind of key pro-inflammatory cytokines being elevated in patients compared to control, and high level of cortisol in exactly the same population. So far, so good. However, just a few years later, we completed a second study. This time, we looked at depression in the context of coronary heart disease patients. So these were older patients, more frail from a physical point of view, but also more inflamed because the coronary heart disease would increase the level of inflammation as a baseline. And we found, again, evidence for inflammation. So depressed patients with coronary heart disease had a higher level of IL-6 compared to patients with coronary heart disease that were not depressed. Serum CRP levels, so C-reactive protein, a biomarker produced by the liver, which is a kind of clinically significant indicator of inflammation, is higher in the depressed patient compared to the non-depressed patient, and same for VEGF level. And interesting, we also found some kind of molecular signature of this because we measured the level of the glucocorticoid receptor. So this is the receptor for cortisol in the immune cells. We measured as mRNA level, and we found lower level of glucocorticoid receptor in the depressed patient compared to the non-depressed patient. So a signature of inflammation and a signature of glucocorticoid resistance, less receptor, less signal. However, the HP axis was completely in the opposite direction. So here you can see the cortisol level measured 3 time points, higher as always in the morning, 2 p.m. bedtime. And patients who were with depression actually had a lower level of cortisol compared to the patients that were not depressed. So almost a mirror picture. So what's going on here? Well, you would imagine that for two fields of research, which have really been going on for dozens of years. I mean, the dexamethasone suppression test was first developed in the kind of 80s. Inflammation and depression has been going on at least for the beginning of the 90s. There should be hundreds of studies that have examined inflammation and HP axis in the same patient. But actually, we recently done a meta-analysis. This is submitted, it's not published yet, and put together all the studies that had a measure of glucocorticoid resistance. So, for example, a dexamethasone suppression test, so other measure that tells us whether the glucocorticoid receptor works or not, together with inflammation. First things I want you to notice, actually there are not many. So that's an area that's, even if we have lots of models and ideas, we have very little data. These studies are organized in this way. They're ranked based on the level of glucocorticoid resistance. So the top study here are the one in which depressed patients were glucocorticoid resistant. These are the ones the patients were more or less similar to control, so they were not glucocorticoid resistant. And these are the ones where actually patients were more sensitive than controls. And as you can see, there is a tendency for inflammation to be higher if there is glucocorticoid resistance, and for inflammation to be indistinguishable from controls if there is no glucocorticoid resistance. But there's also a lot of variability in the studies. So some signal in the right direction, but certainly lots of variability. How do we capture this variability? Where is this variability coming from? So I started 10 years ago from this very simple idea. There is an orange, HP axis hyperactivity, there's an apple, inflammation, and there's some overlap, not complete, but some partial overlap. But obviously that was not enough. At some point we started looking at treatment response. Not all depressed patients are the same. Some patients, for example, are resistant to treatment. And we were the first to demonstrate in a paper that was led by Dr. Cattaneo, Anna Maria Cattaneo, who is in the audience today, that patients with major depression who were resistant to antidepressant treatment have the highest level of inflammation. And in particular, by using two specific pro-inflammatory biomarkers at the mRNA level, interleukin-1 beta and macrophage-inhibiting factors, we were able to identify at the individual levels the chances of response to future antidepressant treatment. So here you can see in this table, the patient that had the lowest level of inflammation, so patient that had lowest level of MIF and interleukin-1 beta, could be classified as green. These were the patients that had 100% chances, 100% of responding to an antidepressant. While the patient with a highest level of inflammation, so the highest level of interleukin-1 beta and MIF, had zero chances to respond to antidepressant, with some patient in the middle having a 50-50 chance. This is now, by chance, a green, orange, and red kind of traffic light metaphor rather than apple and orange. Sorry, I'm kind of mixing up my metaphors as well. Now, why two pro-inflammatory cytokines are better than one? Well, of course, although inflammation co-vary a lot and things that you measure tend to correlate, they also tap into different biological mechanisms. And MIF, for example, tend to be functionally and structurally related to neurogenesis and neuroplasticity relevant pathway, including the glucocorticoid receptor, which again comes back in the equation. While interleukin-1 beta is bang in the middle of the inflammasome, and so is linked to the kind of classic pro-inflammatory cytokines mechanism, including interleukin-6, interleukin-1 receptor, and so on. And we recently replicated this notion in what is probably so far the largest studies in depressed patient and inflammation. This is a study that is conducted in the UK. It's a multi-center study funded by the Wellcome Trust through the NEMA consortium, where we measured inflammation. I'm only going to present the CRP data here because that's what's been published. We measured inflammation in healthy controls, and then in other three groups of depressed patients, treatment responsive, so they were on antidepressant and they were well, treatment resistant, they were on antidepressant and they were not well, and untreated depressed patients who were also not well. And as you can see, again, confirming our previous findings, the treatment-resistant depressed patients are the ones who had the highest level of inflammation. So a message somehow that kind of adding another layer of complexity, the idea that, okay, you have hypercortisolemia, you have high inflammation, and you have treatment response somehow interacting. And not all depressed patients will be treatment resistant, not all treatment resistant depressed patients will be inflamed, but some will be. Is the model complex enough? No, there's more things to come. Because at some point, as we heard today, right before me, and of course yesterday, childhood maltreatment started to appear as an important factors for our understanding of the biology of depression, and in particular for inflammation. We were the first to demonstrate in a paper from 2007 that exposure to childhood maltreatment increased inflammation in adult individuals, even in the absence of depression. And I'm not going to show the data here for lack of time. But we also recently conducted a meta-analysis on all the studies that in the subsequent 12 years have analyzed these questions. And the evidence is quite overwhelming that, in fact, if you measure at least the key pro-inflammatory biomarkers, which I've mentioned many times before, so the C-reactive protein, the interleukin-6, and the tumor necrosis factor alpha, there is an activation of the immune system just because of the exposure to childhood maltreatment. And the meta-analysis, the table is difficult to read. I think the picture I want you to get is, first of all, the number of studies have investigated this, so this is quite a well-validated findings. And then across all of the three biomarkers, CRP here, interleukin-6, and TNF-alpha, and the three biomarkers together, a clear evidence of increased activation, just driven by the exposure to childhood maltreatment. The problem is that, of course, these are not mutually exclusive groups, and that's where the confusion and the frustration, the negative emotion comes in. Because we know the treatment-resistant depressed patient is associated with childhood maltreatment. So we ask the questions, well, is inflammation in our group of patients driven by, rather than treatment-resistant, by the childhood maltreatment? And in fact, in these samples, you can see that we use the childhood trauma questionnaires to measure exposure to childhood maltreatment, and the patient that had the highest level of childhood maltreatment, perhaps not surprisingly, are the ones who are treatment resistant. So the question now becomes, what is driving what? Hypercortisolemia, inflammation, treatment resistant, childhood maltreatment. Not all patients with childhood maltreatment will be treatment resistant. Not all patients with treatment resistance will have been maltreated. Where is the inflammation coming from? So if that model was not complicated enough, of course, we now know that exposure to, the trajectory to depression doesn't really start in childhood. It starts even earlier than that. And Michael Meany has kind of discussed this really eloquently yesterday. The idea that there is a risk of developing depression or mental health problems later in life, it actually starts really early on with maternal history of mental health problems. And we recently published over a few studies, we published the notion that depression in pregnancy not only is associated with an increased risk of offspring mental health problems, but that this increased risk is mediated by an increased risk of the offspring being exposed to childhood maltreatment. So an association between mental health problem in pregnancy, exposure of the child to maltreatment, not by the mother, I want to stress this, is not by the mother, is maltreatment or bullying or other adverse circumstances in the environment. And then this is linked to later risk of mental health disorders. We've published more than one paper. I'm just going to show you this because present the most recent study from the South London Child Development, the most recent data from the South London Child Development Study, which is a cohort that started in 1986, when for the first time my predecessor on the prenatal psychiatry field and at the Institute of Psychiatry recruited a large group of women who were depressed with clinically significant depression in pregnancy and a group of healthy mothers that were pregnant but not depressed. Interesting things about this study is that, of course, the numbers were much smaller. The original sample were in the hundreds rather than in the thousands, so much smaller the current cohort. The Auspach cohort, as you probably know, are many thousands of individuals. But first of all, they looked at clinically significant depression, so they captured the more severe end of the spectrum. And second, because it was the first study to do this, the children always become older first. And so we were always being able to replicate, to identify some of the findings that then were later replicated by the Auspach cohort. And this is one of them. So this is data now from the 25 years assessment. We've been following up the children over 25 years. where for the first time we've been able to ask about maltreatment directly to them rather than using parental information, which we had to do until during the previous assessment. And we clearly showed and replicated this pathway from maternal depression in pregnancy to offspring childhood maltreatment to offspring adult depression. Interesting, there is an association between maternal depression in pregnancy and maternal depression during the offspring childhood. So, as again Michael Meany said yesterday, there is a continuity between depression in pregnancy and postnatal depression. And in fact, we showed that there is a continuity between depression in pregnancy and depression throughout the childhood of the offspring. So it's really a trajectory of depression, a chronic depression that persists almost together with the life, or during the lifetime of the child. However, once you adjust for this effect of depression in pregnancy through maltreatment, depression postnatally doesn't really affect the risk of depression in the offspring. So the impact of depression in utero is much more important than the impact of depression later on, when in theory there is the emotional interaction. Of course, in utero there's a biological interaction, a true exchange of biological mediators, which you don't have later on. Now, if you kind of capture now the additional complexity, you can see that apples and oranges become more and more. Because now we have some patients with childhood maltreatment. Some of them would also be exposed to maternal depression in pregnancy because they are associated. Probably some of them will be treatment resistant. And now I don't know what is driving what. So what if what we always called the effect of childhood maltreatment, for example, the inflammation, which we have, as I showed you 5 minutes ago, we've always associated to exposure to childhood maltreatment. Well, what if it was actually the consequence of depression in pregnancy, since that is also associated with childhood maltreatment? So we have tried to address this question in another study, always in the South London child development cohorts, where we measured inflammation in the offspring at age 25 in the last assessment. And we have compared those who had been exposed to depression in pregnancy, of course, when they were in utero, and those who were exposed to maltreatment and those who were exposed to both. And surprisingly, these are the data. Again, we measure high-sensitivity C-reactive protein. These are the subjects, they're not patients. These are the subjects that are healthy, so they've never been exposed to either depression in pregnancy or childhood maltreatment. And these are the subjects that have been exposed to depression in pregnancy. And as you can see, these are the ones who have a higher level of inflammation. Not, I repeat, not the children who have high level of, who have been exposed to maltreatment but never been exposed to depression in pregnancy. And interesting also that if you have got both, you actually have a slightly lower level of inflammation, as if the immune system tends to become exhausted, which is something we know from animal studies can happen with continuous ongoing stress. So, of course, this is one study, although we're now replicating similar findings in the ASPER cohort, but it kind of, it puts the questions, what are we thinking, what is really driving what? And if all these factors covary together and kind of associate with each other, how do we know where is the primus biological mechanism, where is the first origin of a biological abnormality? Now, of course, things can get even more complicated because we now know that depression in offspring starts in the previous generation. We now know that there is a link between maltreatment in the maternal maltreatment, so mother's maltreatment in their own childhood, and increased risk of depression in the offspring 25, 30 years later, really adding another layer of complexity. And I'm going to show you some data from an epidemiological study, an analysis that we've done of the ASPER cohort, which kind of put all of this data together. And again, this was recently published a couple of years ago in the British Journal of Psychiatry. It is really kind of putting all the usual suspects together. I'm going to kind of walk you through the table. I'm sorry, it's quite dense. But basically, first of all, it shows the well-replicated association between maternal depression in pregnancy or maternal antenatal depression and offspring psychopathology, both internalizing and externalizing disorder. It shows that this is mediated by increased risk of childhood maltreatment, although there is also an additional pathway through postnatal depression, much smaller. But it also shows that everything is driven by maternal childhood maltreatment. So by the exposure of the mothers to in her own childhood to maltreatment, which then drives the depression in pregnancy, which then drives or is associated with downstream cascade. So you can see now why I'm so frustrated, because I really don't know what is driving what, and what are the biological mechanisms, where do these biological mechanisms start? And there are data from Claudia Buss, for example, showing that maternal exposure to maltreatment is enough to change brain structure and brain function in the offspring, at least during childhood. So having kind of used the metaphor of apple and oranges to demonstrate the overlapping and kind of confusing intersection between different risk factors, I wanted to use it also for a possible answer, at least one possible technical development or way of look forward in terms of trying to understand, to put some order in this complexity, which is the idea of really merging data from experimental models, animal and in vitro experimental models, which of course they are models, they have their limits, but at least they are experimentally rigid. They allow us to ask one question at a time with the complexity of human data. And so truly merging data from animals and humans, or in vitro animals and human samples. We've done this in a couple of times now. This is the first time we attempted to do this in a paper that was published a few years ago by Chris Anaker, who is also here it was now in Colombia, but is here at the conference, where we looked at basically the effect of cortisol and stress on neurogenesis. We replicated the well-known findings that stress, both in vitro and in vivo, reduce neurogenesis. But in terms of understanding the molecular mechanism, we compared two models. Human neurons, this is a human hippocampal stem cell line, treated with high dose of cortisol, kind of stress-relevant concentration, and also prenatal stress. So an animal models where pregnant rats are exposed to stress and the offspring have increased risk of developing depressive-like behavior. We did a transcriptomic analysis. We looked at pathway that were differentially regulated. And we identified at least one pathway, the Hedgehog pathway, that was downregulated in both models. Downregulated in both models. And further experiment, which again I'm not going to show for lack of time, demonstrate that this is a mechanistically relevant pathway. So if you stimulate this pathway, which is inhibited by stress, if you stimulate, you avoid all the negative effect of stress on neurogenesis. So this is a way of kind of showing that if you overlap data from different models, you can get mechanisms which are potentially even therapeutically valid. And the last work that I want to show is the work that, again, Anna Cattaneo has done recently with me, in which we truly put together human clinical samples and animal models. We started with the hippocampus of prenatally stressed rats, the model that I mentioned before, conducting transcriptomic analysis and further refined the list of differentially affected genes based on the number of neuronal that were also targeting the genes. And we overlapped that with the genes differentially affected by the transcriptomics in the whole blood of human exposed to adult subject exposed to childhood trauma. The pipeline was more complicated, but I'm kind of summarizing here. We found 22 genes that were differentially regulated in both set of samples, and 16 that were modulated in the same direction. And through network analysis, we could identify 3 key genes which were functionally connected. And again, these are, if you like, the genes in the title of my talk, the fact that even if you don't look for inflammation and glucocorticoid hormones, you end up with inflammation and glucocorticoid hormones using a hypothesis-free approach, because alpha-2 microglobulin is an acute phase protein. It's similarly functional to C-reactive protein. It's functionally connected to IL-6 and to glucocorticoid receptor signaling. TGF-β1 of course, part of the TGF-β signaling system, is linked to IL-12 and also very important for neurogenesis. FOXO1, one of the glucocorticoid receptor activated genes linked to IL-3. So without wanting to say that this is the answer to everything, I just want to show introduce what is our most recent direction of research, something that perhaps could help, if not putting back all science in isolated apple and oranges as I wished it would have been when I started 20 years ago, at least make a little bit more of order in the confusion of the data. There's only a couple of things left for me to say before I finish. First of all is to thank the people that work with me in my lab. This is us ice skating actually in central London, nothing as nice as a frozen lake. This is artificial ice in the middle of central London. And this is Dr. Cattaneo, who was not skating with us, who has done so much of the work. And the last things I want to do is again, a message for the most junior researcher here, that don't expect science to be just handing to you or to us very simple messages, very simple finding, one apple, one orange. In reality, biological psychiatry in general, but biological psychiatry in particular, is complicated, with patients that are a combination of apple and oranges, half apple, half orange, an apple, the patient looks like an apple, but really is an orange, and vice versa. It's complicated, it's fun, that's why we are here. Thank you very much.
Well, thank you very much, Carmine, for a wonderful talk. I'm sure there are questions. Yes, Howard.
For fear of introducing yet another complication, so you talk about maternal maltreatment as leading to these effects, and that's going to lead to maternal depression, and that's going to change the fetal environment. But also, could you comment on the effect of maternal maltreatment epigenetically, and whether there's an epigenetic effect also?
Yes, so epigenetic is an interesting field because the more you study, the more difficult it is to find consistent findings that link across generation. And I think we have in human studies I'm talking about. So we've had difficulties replicating the neat findings from the animal literature into human studies. And I think it just shows again the fact that when we select human samples, we just don't know where is the signal coming from. So for epigenetic studies, we need probably much broader samples than we have so far. So it adds to my negative emotions.
So to repeat the previous question, or at the fear of adding extra complications, I was wondering about the point in time at which you're measuring the inflammatory signals, because it seems like, over a lifespan and at different times in development, and actually at fairly rapid timescales, the different inflammatory factors may be changing over time. And so one question is, how do you know that your measure of those factors at one point in time is representative of something? And then the second question is about, would be interested in your ideas about how the peripheral measurements relate to what's the levels of those inflammatory factors in the brain.
Thank you. These are both really good questions. So partly we are slaves of the data that we have. Longitudinal studies are, as everybody knows in the audience, are difficult to conduct. And most of the time we end up having one measure in one study, another measure in another study. So in the South London Child Development Study, we only have 25 years of age data. In the ALSPAC cohort, they have earlier time point, and this is not published, but we basically been able to replicate the association between depression in pregnancy and increased inflammation at age 9. So it is possible that this is happening at different time point. We also have data from the IRIS cohort finding increased inflammation, but that was in association with childhood maltreatment at age 12. Although, of course, we never measured depression in pregnancy in those samples, so I don't know whether it was really depression, was maltreatment or depression in pregnancy. In terms of the peripheral central link, so I think we definitely think the peripheral inflammation is relevant. It cannot tap into central inflammation. I mean, there's data from Andy Miller's lab showing that inflammatory biomarkers measured in the central nervous system, or at least in the cerebrospinal fluid, correlate. You even see reactive protein, for example, which is kind of a really simple biomarker, correlate with measuring the blood, correlate with inflammation in the cerebrospinal fluid. But also, is the theoretical framework is that it's the peripheral inflammation that really is driving the central one. So it's important to measure because that's what's driving the signal into the brain. So I think for that reason, I'm kind of quite confident that this data are biologically relevant.
I think there's one more question.
Hi, thank you so much for a fantastic talk.
Thank you.
With fear of throwing a third wrench into the ideas that we have here already, as you know and as you explained so beautifully, there are multiple ways to lead to the same end of this sustained peripheral inflammation in a person's body. And what I was wondering is if these risk factors that we're seeing here are also giving rise to certain pathogens and dysbiosis in the person's systemic microbiome. And that could even be continuing to propagate the system, or even like if the person was at risk and not necessarily depressed and systemically inflamed, quote unquote, yet, that would actually be a downfall.
So again, I mean, the microbiome, as you said, adds a completely new level of complexity, even just by the difficulty in studying it and analyzing the data. We know that abnormal microbiome could be one of the mechanisms through which stress leads to inflammation because of disrupting in the gut permeability and access of kind of inflammatory mediators from the gut. So it is possible that one of the reasons why childhood maltreatment or other forms of stress creates inflammation is not only kind of sympathetic innervation, but also through gut permeability. Again, it's a very important topic. I mean, I was at the editorial board of Biological Psychiatry today, and some of the top-cited papers are on microbiome, so I think you're spot on. Yeah.
Thank you.
Thank you.
Thank you very much indeed, Carmine, for an absolutely wonderful talk. Thank you.